Now we're going to start talking about medications for attention deficit hyperactivity disorder. The anxiolytics, such as caffeine and Provigil, treat fatigue, drowsiness, analgesia, and narcolepsy. There's many unlabeled uses as well. These include atopic dermatitis topically, obesity, headaches, and adjunct in migraines, as well as ADHD and depression. The amphetamine-like drugs include Adderall, Dexedrine, methamphetamine. These drugs treat narcolepsy, ADHD, obesity, and some of the unlabeled uses include cocaine dependence and autism. There are both short-acting, intermediate. There are also short-acting, intermediate-acting, and long-acting medications. The short-acting are Ritalin. Intermediate-acting include Ritalin SR. Long-acting include drugs like Concerta, Methadate CD, Ritalin long-acting, Datrina, transdermal system, and dexmethaphenidate. The amphetamines, short-acting, include the dexedrines, the methamphetamines, disoxin. The intermediate-acting include drugs like Adderall, and the long-acting include Adderall XR. Norepinephrine reuptake inhibitors include Strattera, which is treatment for ADHD. There's also the antidepressants such as the tricyclics, trophanil and disopramin, and the amyoketones such as bupropion, which the other word for is Wellbutrin, Zyban, and Wellbutrin XL. So many persons with ADHD or ADD pay too much attention to too many things. This leads them to have little focus rather than having too little attention. Both amphetamines and amphetamine-like drugs act to alter levels of the neurotransmitters in the brain, thereby modifying behaviors to improve and maintain function in patients with attention deficit disorder, with or without hyperactivity and narcolepsy. Atomexatine, which is indicated only for the treatment of ADHD, increases the extracellular concentrations of norepinephrine. Although the precise mechanism of efficacy in ADHD is unknown, antidepressants are used occasionally in children who have failed to respond to other therapies. Modafinil is a CNS anxiolytic with a unique mechanism of action. It's used to treat excessive sleepiness associated with narcolepsy, obstructive sleep apnea, and shift work sleep disorders in adults. It does not have FDA approval for use in ADHD, but you must remember an anxiolytic is a drug that acts as a stimulant to the CNS. Caffeine is the most common anxiolytic seen in primary care. It is used on an over-the-counter basis to help people stay awake and restore mental alertness, and as an adjunct in analgesic formulations. You'll see this in migraine headache medications. Furacet includes such drugs as caffeine. And methylxanthine is also caffeine is considered methylxanthine. The extended release clonidine was approved in the late 2010 as an adjunctive therapy to stimulants for ADHD or as a monotherapy. Amphetamines, which have a very high potential for abuse, are Category 2 drugs. They are used primarily in long-acting formulations, which may make dosing easier for ADHD in primary care. Methylphenidate, a commonly used drug, is similar to the amphetamines but has less abuse potential, although it is a Schedule II drug as well. New longer-acting formulations have been developed, and these provide more options for dosing. Miscellaneous drugs with central alpha agonist action, tricyclic antidepressants, disopyramine, and anxiolytics have also been approved for ADHD. Unlabeled uses include depression, pain control, sedation for patients on opiates, cognitive impairment, and chronic fatigue syndrome. So looking a little more at the anxiolytics, caffeine, which is a methylaxanthine, competitively blocks adenosine receptors and is a potent stimulant of the central nervous system. It also produces cardiac stimulation, dilatation of coronary and peripheral blood vessels, constriction of cerebral blood vessels, skeletal muscle stimulation, augmentation of gastric acid secretion, and diuretic activity. For this reason, you can suspect that there are many side effects. It may produce tachycardia or premature ventricular contractions as well. The CNS stimulating effect and associated constriction of cerebral blood vessels are effective as analgesic adjuncts. It also increases absorption of ergot alkaloids, and you need to keep in mind that tolerance to these agents may develop. The modafinil is a pharmacologically distinct psychostimulant approved for the use in shift work, sleep disorders, sleep apnea, narcolepsy, and excessive daytime sleepiness in adults. Although the exact mechanism of action is unknown, studies have demonstrated that it inhibits the reuptake of dopamine and activates glutamatergic circuits while inhibiting the GABA. It is thought to have less abuse potential because of the absence of euphoric effects. It is used off-label but recommended mostly for ADHD. So for the amphetamine-like drugs, methylphenidate is a mild cortical stimulant with CNS action similar to those of amphetamines. It inhibits the reuptake of norepinephrine and dopamine in the cerebral cortex. This results in an increase in neurotransmitter in the synaptic cleft and enhanced stimulation of the cerebral cortex and subcortical structures. In normal children, as well as children with ADHD, this effect enhances the child's ability to selectively filter stimuli, leading to a decrease in motor activity and an increase in attention and cognition. Dexmethylphenidate contains the more pharmacologically active of the dextro and levo isomers. The amphetamines are symphomimetic amines with a CNS stimulant activity as well. Norepinephrine is released from the central noradrenergic neurons at high doses. Dopamine may be released. The site of action for appetite suppression is thought to be in the lateral hypothalamic feeding center. Peripheral alpha and beta activity includes elevation of systolic and diastolic blood pressure, and weak bronchodilator and respiratory stimulant actions. Dexamethasone is a prodrug of dexamphetamine and is a relatively new product. Norepinephrine reuptake inhibitors, the mechanism of action of Odomexetine is selective reuptake of presynaptic norepinephrine. It does not bind to monoamine receptors in the brain, thereby decreasing the risk of adverse reactions compared to the older norepinephrine reuptake inhibitors. You must keep in mind that this is an active area of research and has increased over the last decade, and many new drugs come out, and we need to just keep up to date with these. So for treatment principles, this is a difficult area because a lot of the time these are children. The evidence-based recommendations state that it's likely to be beneficial, including the Odomexetine, dexamphetamine, sulfates, methylphenidate plus psychological behavioral treatment. Methylphenidate improves core symptoms and school performance in children with ADHD when used alone, and it may be beneficial when added to a psychologic behavioral treatment. Dexamphetamine and amoxicillin may also reduce the symptoms of ADHD, but can cause adverse effects. So for the cardinal points of treatment options include counseling for the parents or guardians as well as the teachers. They need to know what to expect from these drugs as well as adverse reactions. First line, all agents are similarly effective. Methylphenidate has the best track record. Long-acting methylphenidate for the child has difficulty taking multiple doses during the day, and amphetamine salt. The tricyclic antidepressants such as disperidine and nortriptyline for patients with a history of substance abuse, bupropion for patients with a history of cardiac disease or other medical conditions, medical contraindications to stimulants. When moving between different drugs or different drug formulations, carefully follow the FDA-approved drug conversion formulas. Starting in 2011, the American Academy of Pediatrics has recommended that all patients 4 to 18 years who show symptoms of ADHD be evaluated. Previous recommendations call for the diagnosis and treatment of ADHD in children aged 6 to 12, but researchers said that behavior disorders, attention problems, and overactivity can manifest at an earlier age. This is why we're seeing younger children on these medications now, more than we have in the past. Non-pharmacological treatment, drug therapy is not indicated for all children with the syndrome. Stimulants are not intended for the use in children who exhibit symptoms related to environmental factors and or primary psychiatric disorders, including psychoses. Appropriate educational placement is essential, and psychosocial intervention generally is needed. You can't just treat the condition with medication. There needs to be additional support. Classes or counseling for parents and behavior modification, such as a point system that allows children to earn rewards, is often considered an integral part of the treatment plan for ADHD. Additionally, social skills training, cognitive behavioral therapy, support groups, biofeedback, and have all been integrated into comprehensive multidisciplinary management programs. Evidence, however, empirical evidence for the efficacy of these interventions is, however, lacking. However, the most success is seen with multidisciplinary programs. The new American Association of Pediatrics provides guidelines with specific information on working with parents and teachers to obtain the best treatment results. For pharmacological treatment, when non-pharmacological measures alone are insufficient, a decision to prescribe stimulant medication will depend on the clinician's assessment of the chronicity and the severity of the child's symptoms. All available stimulants appear to be equally effective. Methylphenidate is usually the first-line drug for choice in ADHD. When giving medications to children, you must obtain permission from the parent or guardian. Although some families may choose not to inform their child's teacher of the decision to medicate, teachers may be very helpful in evaluating response to the therapy. There's something called a Connors Teacher's Rating Scale, which is completed prior to the initiation of therapy and 1 to 2 weeks after the initiation of therapy, and this may provide a standardized assessment to the child's response to the medication. Additionally, parent rating scales should be completed before and after therapy is begun. A once-daily formulation of methylphenidate, the other name Concerta, may be used to help children for whom multiple doses per day are difficult. If paradoxical aggravation of symptoms or other adverse effects occur, reduced dosage or it may be necessary to discontinue the drug. Duration of therapy is unknown and is highly individualized. Most studies of stimulants have been short-term trials that demonstrated efficacy over weeks to a year. Increasingly, treatment is continuing into adulthood, and although drug holidays during school breaks in the summertime are still common, children who exhibit impairment in both home and school settings may require treatment on all days of the year. If the patient does not respond to methylphenidate, other medications from another class may be considered. Amphetamines usually are used. Adderall, very common and contains both amphetamine and dextroamphetamine. At higher doses, its duration of action is prolonged. In clinical practice, many adults with ADHD do respond to dosing with FDA-approved maximums, which currently is 20 milligrams a day for D-methylphenidate XR and 20 milligrams daily for mixed amphetamine salts XR or Adderall. Other stimulant preparations approved for children and adolescents, ADHD, have not yet been approved for adults. Approved doses reflect the failure of studies submitted to the FDA to demonstrate significantly greater benefit with higher doses. There is emerging evidence that indicates that some adults with ADHD may tolerate and benefit from higher doses than those approved by the FDA. In converting one product to another from different formulations, FDA recommends conversions for psychostimulants are always approximations, especially when one is converting between stimulants, such as methylphenidate and dextroamphetamine. Different pharmacokinetics exist for different drug formulations, and patients often have different responses to them, as with many of the other medications. Conversions between short-acting and long-acting preparations for the same drug should try to match serum concentration curves and not clinical performance curves. Ratios for converting among medications in clinical practice is complex. This may vary by ADHD symptoms, comorbidities, and the patient's metabolism, as well as adverse effects. Common approximations for conversions must be individualized with close follow-up and possibly titration if necessary with the initial doses. Some conversions for children include converting, for example, methylphenidate. Long-acting CD or ER preparations convert by using a ratio of 2 to 1 with immediate release methylphenidate. For example, with Ritalin, 10 milligrams Q4 hours is converted to Ritalin long-acting 20 milligrams Q8 hours. For a few patients, effects last only 5 to 6 hours with the long-acting preparations, although effects last 3.5 to 4 hours with the IR form. However, a short effect from one 8-hour preparation does not always mean another 8-hour preparation has the same. For XR mixed amphetamine salts, you need to convert using the 2-to-1 with IR. The half-life of mixed amphetamine salts widely varies among individuals. Some patients do better with the slower second dose and may benefit from an IR or an XR morning combination. Dexedrine, Spancel seems to have the greatest interpatient variance when converting the IR form to the CR form. The IR to CR ratio for equivalent clinical effects appear to vary from 1-to-1 to about 1-to-1.5. However, this conversion has not been well studied. For example, dextrostat 10 milligrams Q4 hours is then converted to Dexedrine CR 10 to 15 milligrams Q8 hours. Methylphenidate osmotic release oral system, the other name for this is Concerta. These tablets are converted in an 18-to-5 ratio with methylphenidate. For example, Ritalin 10 milligrams Q4 hours converted to Concerta is 36 milligrams. For many patients, Concerta tablets last only 9 to 10 hours, and patients also commonly describe the medication as taking longer than others to take effect. Methylphenidate OROS or Concerta tablets are converted at an 18-to-10 ratio with methylphenidate long-acting CD or ER. For example, Ritalin long-acting 10 milligram Q8 is converted to Concerta 18 milligrams. Methylphenidate transdermal patch is converted in a 1-to-1 ratio with methylphenidate IR and a 1-to-2 ratio with long-acting preparations, although the FDA suggests starting with the lowest dose patch and work upward. Lisdexamfetamine dosing conversion may be compared with dextroamphetamine immediate release or Dexedrine IR. The prescribing information describes a dose of lisdexamfetamine 100 milligrams as an equivalent to D-amphetamine sulfate immediate release 40 milligrams. For the TCA or tricyclic antidepressants, these have been used as both primary and adjunctive therapy in children who fail to achieve a positive response to stimulants. The specific agents used are desparamine and nortriptyline, primarily because of their effects on norepinephrine reuptake. They have produced a favorable response in patients with ADHD and generally are avoided in patients with cardiac disease, specifically conduction abnormalities. Bupropion is an antidepressant that has a norepinephrine and dopamine. That has effects on norepinephrine and dopamine. It has been shown to be effective in ADHD in as little as 2 weeks. However, studies are limited, and this use is off-label. An alternate choice to amoxicillin is amoxicillin. Currently, it's used for patients who cannot tolerate CNS stimulants, although it also may be used for patients who wish to avoid stimulants or patients with a history of substance abuse. Alternative therapies include antioxidants, vitamin and mineral preparations, especially copper, zinc, selenium, and B vitamins, and herbal extracts. Valerian root, kava kava, ginkgo biloba, and pink bark extract have been used. However, because these are herbals, the safety and efficacy of the herbal extracts remain unknown. So how do we monitor treatment? In 2006, the FDA requested that all stimulant medications include a label change for all drugs in the class in which sudden death has been reported in association with CNS stimulant use at usual doses in some pediatric patients who have structural cardiac abnormalities. This warning appears as a black box warning for cardiovascular risks. The American Heart Association recommends careful screening for all children and adolescents prior to initiating pharmacological therapy for ADHD, including a detailed patient and family history and physical exam. Ideally, a baseline echocardiogram should also be obtained and careful follow-up monitoring instituted. Although research suggests that only 24% of 525 pediatricians believe that cardiac screening should be conducted before stimulants are prescribed to children with ADHD. 93% of the respondents completed a routine history and physical on their patients. In an FDA report released more recently in 2012, patients aged 2 to 24 who use stimulant medications for ADHD were found not to be at higher risk for cardiovascular events compared to those non-users. This is in contrast to the previous findings with that these medications were associated with higher incidence of stroke and MI. The FDA does recommend that clinicians periodically monitor the heart rate or blood pressure of patients on ADHD drugs, but are less strict to requiring a full cardiac workup. Other important precautions on product labeling now include the potential for exacerbation of existing psychiatric conditions or new onset episodes of psychosis, aggression, or mania in children and adolescents receiving ADHD drugs. This needs to be told to the parents, and they might want to notify their teachers as well. Patients should be seen more frequently during the dosage adjustment period, although some follow-up may be conducted through phone consultation. Once patients are stable, they should be followed once every 6 to 12 months, and blood pressure and weight should be monitored. Children with known seizures or tics should be followed closely, particularly at therapy initiation and following a dose increase, because these drugs may escalate these disorders. We also need to think about use and abuse, drug dependence. Use with caution in emotionally unstable patients and those with a history of alcoholism or drug dependence. Chronic abuse can cause frank psychotic episodes. Withdrawal from the drug should be monitored because severe depression may occur. And it is well known that once patients are started on antidepressive drugs, they're at greater risk of suicide. Chronic abusive use can lead to marked tolerance and psychological dependence with varying degrees of abnormal behavior. For this reason, you must monitor the patient both adjusting the dose or stopping the medication. Frank psychotic episodes can occur in these patients. You need to think about patient variables. Geriatric patients, methylphenidate has an unlabeled use in the elderly population. It may increase mental alertness and stimulate appetite. Low doses and careful monitoring is required. You must also monitor cardiovascular status closely. Many patients will be unable to tolerate the stimulant effects. In pediatric patients, use in children younger than 6 years of age is off-label. However, it is currently done, and you'll see a lot of younger children started on these medications. For patients who are pregnant and lactating, studies conducted for any of these drugs have not been adequate to determine their safety and are not recommended for women of childbearing age. For gender considerations, women who use modafinil and oral contraceptives should take precautions to avoid pregnancy. Now we will move on to antidepressants. These are very commonly prescribed in primary care, and there are many to choose from. Selective serotonin reuptake inhibitors, or the SSRIs, include Prozac, Celexa, and Paxil. All of the SSRIs work by increasing the amount of serotonin by blocking the presynaptic serotonin reuptake pump. At least 14 different postsynaptic serotonin receptors are present in humans, and each of these receptors control a different psychologic or a psychiatric function. The action of the SSRIs is related to which postsynaptic receptor is stimulated. It's believed that the 5-HT1A receptors are primarily responsible for the antidepressant effect, and that the other receptor subtypes may be responsible for some of the other side effects of SSRIs. The SSRIs are the most commonly used first-line therapy. They produce only a marginal response when compared to placebos, or at best a 20% better response rate than placebo in some of the trials that have been done. They are similar in action and response, and the one used varies depending on the clinician's familiarity with the medication and individual patient responses. Most of the SSRIs are somewhat questionable safety profile, particularly when weight gain and risk of suicide is considered. The serotonin norepinephrine reuptake inhibitors, such as Effexor, SR, Cymbalta, are non-tricyclic antidepressants with dual serotonin and norepinephrine reuptake inhibition and weak reuptake inhibition of dopamine, and that has demonstrated efficacy in the treatment of depression and produces fewer side effects than produced by the tricyclics. Thus, they act on all three of the monoamine neurotransmitters, as does the tricyclic antidepressants. However, different from the tricyclics and similar to the SSRIs, Effexor has virtually no affinity for muscarinic, histaminic, or alpha-1 adrenergic receptors. The side effect profile is closer to that of the SSRIs than the tricyclic antidepressants, and at higher doses, the risk of high blood pressure is increased. Another SNRI, Cymbalta, was approved for the treatment of major depressive disorder, and this is an inhibitor of serotonin and norepinephrine reuptake, and a lesser inhibitor of the dopamine reuptake. Milnacipran is a non-FDA approved antidepressant, is also used as an inhibitor of norepinephrine and serotonin reuptake. The SNRIs, bupropion, Wellbutrin is the other name, are also commonly used in primary care. All depressants have heavily prescribed by providers, including the so-called adjuncts, although there are marginal objective data supporting their use. MAOIs are used as third-line agents in case of refractory or atypical depressions. These generally are prescribed by a psychiatrist, not the primary care provider. Norepinephrine and dopamine reuptake inhibitors include bupropion, is structurally similar to amphetamine and considered different from other antidepressants. They act weakly as norepinephrine and dopamine reuptake inhibitors. It uniquely increases dopamine in the nucleus accumbens, which is known as the reward area of the brain in smokers. Therefore, it's used as a treatment for smoking cessation. Tricyclic antidepressants, again, these were discovered in the 1950s and are named for their chemical structure, which includes 3 rings, thus tricyclic. They are subdivided further into their tertiary and secondary amines. The secondary amines, dysparamine and nortriptyline, are metabolites of the tertiary amines, such as amitriptyline and imiperamine. This results in significant differences in the pharmacokinetic as well as the pharmacodynamic effects of each drug. TCAs exert their therapeutic effects by blocking or inhibiting reuptake of norepinephrine and serotonin at the presynaptic neurons. They block the reuptake of dopamine to a lesser degree than serotonin. Some of the tricyclics block 5-HT receptors and added therapeutic action. In addition, they block cholinergic, histamine, and alpha-1 adrenergic receptors. This effect is associated with the many side effects of the tricyclic antidepressants. Tricyclics also block sodium channels in the heart and brain, which can cause cardiac arrhythmias and seizures. The use of the tricyclics have definitely decreased over the years since the newer drugs have been placed on the market. However, many of the tricyclics are available. These agents produce acceptable results in patients who have not responded to one of the other antidepressants. They also are used when cost is a concern and as an adjunct treatment for depression and pain. Nafoxidone is used only when other agents have failed. It carries a black box warning for liver toxicity. Trazodone is used largely as an adjunct to induce sleep. MAOIs are used as third-line agents in case of refractory and atypical depression. The noradrenergic antagonist, these were introduced in 1997. Mirtazapine as a tetracyclic compound that is unrelated to the tetracycline antidepressants. It's an alpha-2 antagonist that blocks the alpha-2 receptors on the adrenergic neurons. The alpha-2 receptors are non-adrenergic receptors that act as presynaptic autoreceptors. When they detect adequate levels of norepinephrine, they stop norepinephrine release. An alpha-2 antagonist will block the negative feedback loop, raising norepinephrine levels. This same mechanism also will stop norepinephrine from blocking serotonin release, thus raising serotonin levels. The drug blocks 3 serotonin receptors, 5-HT2A, 5-HT2C, and 5-HT3, and has an antihistaminergic properties. Serotonin 2 antagonists, or serotonin reuptake inhibitors, blocks 5-HT receptors and serotonin reuptake presynaptically and postsynaptically. Their most powerful action is to block the 5-HT receptors. This is called 5-HT antagonism. They block serotonin uptake, as do the SSRIs, but this is a less potent action. They are weak alpha-1 adrenergic blockers. Trafaxidone is a weak blocker of norepinephrine reuptake inhibitors. The most common name for this is Cerazone. It has virtually no affinity for cholinergic alpha-2 or beta-adrenergics, dopamine D1, D2, or histamine receptors. Trazodone blocks histamine 1 receptors, and this is what causes sedation. The MAOIs are monoamine oxidase inhibitors. The monoamine neurotransmitters, dopamine, norepinephrine, and serotonin are blocked down by the enzyme MAO, and the MAOIs are the medications that block this breakdown, causing increased levels of these 3 neurotransmitters. The first two MAOIs that blocked the MAO enzyme were irreversible. The very new ones are reversible inhibitors of MAO, known as reversible inhibitor monoamines. So what are their indications? These drugs are used for major depression, anxiety disorders, FMPs, smoking cessation. Other indications include PMDDs, OCD, bulimia, panic attacks, PTSD, anxiety, both social and general. There's also some unlabeled uses include pain, headaches, hot flashes, neuropathy, and insomnia. Their mechanism of action: increased monoamine neurotransmitters, serotonin, norepinephrine, and dopamine may produce an elevated mood, but that does not always signify the successful treatment of depression. Some researchers firmly believe that the antidepressants are ineffective because they treat the symptoms, not the depression. All current antidepressants act on neurotransmitter systems by affecting three distinct processes: neurotransmitters degradation, neurotransmitter reuptake, or the reabsorption into the releasing cell, and neurotransmitter binding. Degradation of all three neurotransmitters is accomplished by the MAO enzyme. This catechol O-methyltransferase, which is an enzyme, it degrades the norepinephrine and dopamine. MAO degrades neurotransmitters after reabsorption into the presynaptic neuron. And the MAOs occur in two forms, the MAO-A and the MAO-B, and are present in tissues throughout the body. Drugs that inhibit the enzyme result in increasing the concentrations of neurotransmitters known as MAOIs. The next mechanism of action of antidepressants involves inhibiting the reuptake of neurotransmitters in the synapses. Neurotransmitters are removed from the synapses by reuptake pumps on the presynaptic neuron, which takes them up and stores them for further use. Inhibiting this reuptake enhances the amount of neurotransmitter in the synapses. And then the third mechanism of action of antidepressants involve neurotransmitter binding, receptor binding sensitization. This is a delayed effect. In the Edmonds text, table 47.5 shows antidepressants classified according to their mechanism of action. This is very difficult, to first learn, but if you can classify these medications and have a general understanding of the mechanism of action, you'll understand how to treat your patient and what to expect. All categories of antidepressant medications have a common major mechanism of action. Slight variations within a drug category may be noted. Older medications tend to have additional side effects, whereas the newer antidepressants demonstrate a trend toward more specifically tailored mechanisms of action. Antidepressant therapies are not categorized as SSRIs, TCAs, or MAOIs. Have also been developed. These are referred to in the literature as atypical antidepressants. These drugs include the Wellbutrin, the Cerazone, and the Desrel. So let's talk a little about the cardinal points of treatment. First, you must establish a diagnosis. It's very important to assess for suicidal risk. Research has demonstrated that Primary care providers write more prescriptions and see more patients frequently in the month before a patient commits suicide than mental health specialists do. This is pretty scary. Providers must know the risk of suicide and be aware of warning signs that suicide is contemplated. The clinical evaluations of these patients is often challenging, as antidepressants can hide often many of these signs, and can be many of the symptoms can be misdiagnosed as anxiety. Medications prescribed for anxiety, such as benzodiazepines, which are seen as depressants, would not be appropriate for a depressed person. You should institute counseling or psychotherapy. This is often ignored or ineffectively communicated to the patient, and begin drug therapy as needed. Choose the drugs based on adverse effect profile, cost, and patient preference. Again, in Edmonds' book, Chapter 47, there's a box 47.3, which has a nice, provides a nice information looking at these different ways to choose therapy. You need to assess the patient's status, therapeutic response, and adverse effects of therapy on a regular basis. You need to monitor for increased suicidal thoughts and behavior. For patients with akathisia, do not supplement with benzodiazepines. You need to modify the treatment if the patient does not have an adequate response, and continue therapy for at least 4 to 9 months for the first episode of MDD. There are some FDA warnings. There is updated information on the label regarding drug interactions. Chief among the concerns are the serotonin syndromes or neuroleptic malignant syndrome, like reactions with the SSRIs or SNRIs alone, but are more likely to occur with use of both the serotonergic drugs, including the triptans, agents that impair serotonin metabolism, including the MAOIs or antipsychotics and other dopamine antagonists. Symptoms of serotonin syndrome are pronounced, and they include mental status changes, agitation, hallucinations, and coma, autonomic instability symptoms, nausea, vomiting, and diarrhea. Severe cases can resemble the neuroleptic malignant syndrome, which includes the hyperthermia, muscle rigidity, autonomic instability with possible rapid fluctuation in vital signs, and mental status changes. Patients should be monitored for the emergence of serotonin syndrome or neuroleptic malignant syndrome, and family members should be educated about the signs and symptoms of these syndromes. Continued treatment of depression with MAOIs and SSRIs or SNRIs at the same time is contraindicated. SSRIs or SNRIs treated patients receiving the triptans should be observed closely, particularly during initiation of therapy, dose increases, or the addition of another serotonergic drug. Concomitant use of SSRIs or SNRIs with serotonin precursors, such as the tryptophan, is not recommended. Treatment with SSRIs or SNRIs and any serotonergic or antidopaminergic agents, including the antipsychotics, should be discontinued immediately in patients for whom symptoms of serotonin syndrome develop. Depression is generally treated in the primary care setting. Patients should be referred to psychiatrists, include those who fail to achieve remission, who have symptoms of psychosis or severe symptoms, or have depression with other comorbid psychiatric illness. Life-threatening situations such as the risk of suicide must be referred to the emergency department. Patients who are not eating or drinking should be sent urgently to psychiatry for consideration of electroconvulsive therapy. Children and adolescents who often present with complex situations all should be referred to a specialist. Patient preference is a major factor in the decision of which treatment to use. Many non-pharmacological modalities are available for the treatment of patients with depression, including medications, psychotherapy, ECT, light therapy, and herbs. These may be used alone or in combination. Life-threatening situations such as the risk of suicide must be referred to the emergency department. If there's any question that this patient is at risk for committing suicide, don't think twice. Children, again, and adolescents often present with complex situations. These all should be referred to a specialist. Again, patient preference is a major factor in the decision of which treatment to use. Non-pharmacological treatment for depression is important. The primary care provider often can teach simple procedures that make important contributions to recovery, such as relaxation techniques, exercise, diet, and sleep hygiene. Exercise is especially important, with research suggesting that more vigorous walking or aerobic exercise is the most helpful but has the highest dropout rate. Those who get 2.5 to 7.5 hours of exercise per week have better mental health. Beyond 7.5 hours may increase symptoms of depression and anxiety across age groups. Guidance on daily routine may help get the patient moving. These requirements may be written on a prescription pad or established through contract with the patient if the patient believes it will be helpful in having the patient take them seriously. Psychotherapy may be considered alone as initial therapy. Therapy is especially helpful for patients with psychosocial stressors, interpersonal difficulties, and other psychiatric illnesses. Psychotherapy should be recommended to all depressed patients. Often they will refuse treatment because of the associated social stigma or lack of insurance reimbursement. However, data supports both psychotherapy and medications for patients with severe, chronic, longer than 2 years, or recurrent symptoms. Occasionally, patients are more receptive to psychotherapy after the antidepressant has started to work. ECT is useful for patients who have severe functional impairment, such as those with catatonia, patients who refuse to eat, drink, or take medications, and those with symptoms of psychosis. Among patients who don't respond to antidepressants, adding cognitive behavioral therapy to their prescription appears to diminish depressive symptoms. Pharmacological treatment, researchers suggest that most commonly prescribed antidepressants are similar in effectiveness to one another, but differ when it comes to possible side effects. The findings, based on the Agency for Healthcare Research and Quality review of nearly 300 published studies of second-generation antidepressants, showed that about 6 in 10 adult patients get some relief from their medications, and about 6 to 10 also experience at least one side effect, ranging from nausea to sexual dysfunction. Those patients who do not respond often try another medication within the same class. About 1 in 4 of those patients recover, according to that review. Second-generation antidepressants, which include the SSRIs and SNRIs, often are prescribed because first-generation TCAs can cause intolerable side effects and carry high risks. Evidence is insufficient to predict which medications will work best for individual patients. When agents have equivalent efficacy, consider adverse effects, cost, and patient preferences when prescribing second-generation antidepressants. Regular assessment of patient responses and adverse effects, changing drugs when necessary, and continuing therapy for adequate periods of time all help in achieving the best results. For the acute treatment phase, this begins when the diagnosis is established and lasts approximately 6 to 8 weeks. Remission, which is the treatment goal, is defined as return to baseline level of symptoms and severity. The initial response rate to antidepressant drugs has been reported in the literature as ranging between 50 to 60%. If started during the acute treatment phase, although placebo response rates may be as high as 40%. About 45% of the patients receive or achieve remission. Medication should be started at low doses that is increased gradually until the desired response is attained or until side effects that influence compliance develop. The provider must inform the patient what side effects are likely to occur and must help the patient cope with these side effects. If the patient shows a partial response in the first weeks, continue the trial of the medication for another 2 to 4 weeks. Maximum effectiveness cannot be evaluated until the patient has been on the same dose for at least 4 to 8 weeks, depending on the medication. This is very important to tell your patient because they will expect immediate results, and this does not happen. It takes 4 to 8 weeks. Once the patient has responded to a medication titration, the dose you need to titrate the dose until the patient has remission or experiences significant side effects. It is important to continue to adjust treatment to achieve remission instead of partial response. If the patient has no response after 8 to 12 weeks, gradually discontinue the drug. A second drug trial may come from the same or a different drug class. If a second drug from one category fails, choose a drug from another class. When the switch is made to another drug, the new drug should be started while the first drug is tapered over 2 to 4 weeks, except for Paxil, which does not need to be tapered because of its long half-life and active metabolite. The first step in treatment for a person with bipolar disorder is mood stabilization. Rapid cycling may be prompted if care is not taken. If providers have little experience treating bipolar disorder, the provider should refer these patients to whom the condition is suspected. For augmentation, for partial responders, a second antidepressant drug is frequently added for partial responders. The provider must consider the additional risks that come with dual therapy and may opt to refer the patient to a psychiatrist. Partial responses generally can be divided into 2 categories. This affects the choice of augmentation. An apathetic responder may continue to have lack of pleasure, decreased libido, and lack of energy. An anxious responder may continue to have anxiety, excessive worry, insomnia, and somatic symptoms. The use of lithium and atypical antipsychotics such as risperidone, clozapine is best prescribed and managed by a psychiatrist. Wellbutrin and SSRI and methylphenidate Ritalin may be used for apathetic responders. Trazodones, TCAs, mirtazapine, sedating antihistamines, and sedatives may be used for partial responders who remain anxious. When anxiety persists or worsens, consideration should be given to reassessing the patient, ensuring that anxiety is not exacerbated by the antidepressant or the titration of the antidepressant. In addition, antidepressants may induce akathisia that is often mistaken for worsening anxiety. Careful assessment and reassessment are warranted in cases of persistent anxiety unassociated with pharmacotherapy. The addition of a second drug such as trazodone or mirtazapine could be considered, but this should be done rarely and only under the supervision of a psychiatrist. For the continuation phase, once the patient achieves remission, the continuation phase begins. This lasts for about 16 to 20 weeks. The goal is to preserve remission and prevent relapse. Relapse is defined as reemergence of significant symptoms following remission. The patient must be monitored closely during this phase. For the maintenance phase, if the patient completes the continuation phase without remission, the maintenance phase is entered. Maintenance generally consists of continuing the medication prescribed during the treatment phase. The goal here is to prevent recurrence. Duration of treatment depends on many factors. Treatment initially provided to a patient who has simple depression that is in remission usually lasts 4 to 9 months. Dosage reduction generally is not recommended. Those who probably will require an indefinite pharmacologic treatment maintenance phase include those who have a response without remission, those who have more than one episode of depression, the elderly, and patients with symptoms of psychosis, depression of long duration, and severe depression. If treatment is stopped, regular follow-up with the patient continues to be necessary to monitor for relapse. In general, depression is a lifelong chronic recurrent illness that requires lifelong treatment. In choosing which drug should be used, consider each neurotransmitter regulates different functions that are important to mood. To summarize briefly, norepinephrine tends to regulate alertness, energy, vigilance, and interaction with the environment. Dopamine regulates motivation, pleasure, and reward. And serotonin usually regulates inner equilibrium, anxiety, obsessions, and compulsions. So you can choose the drugs related to how each of their neurotransmitter regulates. When selecting a drug, consider the mechanism of action of the drug and the therapeutic effect of the neurotransmitters affected. Review the patient's complete history and physical exam for factors that may influence your choice. Consider the patient's age and gender, along with history of previous responses of the patient or family members, because research into pharmacogenetics suggests that genes may influence responses to antidepressants. Consider the side effects associated with each drug. This is probably the most important factor that affects patient compliance and treatment. Dosing is also a factor in drug choice. Refer to the side effect profile of each drug for recommendations about what time of day is best to take the drugs. For example, Paxil has a tendency to cause insomnia, so it's best taken in the morning. Cost is also an important factor to the patient. Antidepressants tend to be expensive, and some insurance plans do not cover all medications. Generic versions generally are less expensive. However, most generic antidepressants have not been on the market long enough to allow for much cost reduction. TCAs tend to be less expensive than other types of antidepressants, but in patients whom suicide may be a large consideration, TCAs are highly toxic in overdoses, whereas other, such as SSRIs, are far less toxic. Serotonin syndrome is potentially a lethal array of symptoms that are consistent with overactive stimulation of the CNS. It results from overstimulation of 5-HT receptors, which can be caused by co-administration of any drug that increases serotonin, including the SSRIs, the MAOIs, bupropion, SNRIs, lithium, antipsychotics, dopamine agonists, tryptophan, amphetamines, triptans, and psychostimulants. The patient may display hyperactivity, tachycardia, hypertension, tremulousness, GI distress, sweating, altered mental status, fever, agitation, tremor, myoclonus, and hyperthermia. Symptoms generally appear within the first 24 hours and are treated with supportive care. And of course, you discontinue the medication immediately. Selective serotonin reuptake inhibitors are the most commonly prescribed for a variety of reasons. They are well tolerated and considered safe in overdose. Symptom relief usually is seen within 3 to 6 weeks. Side effects appear immediately, but generally resolve in less than a week. Sexual dysfunction in both men and women is common to this class of drugs and is seen in as many as 50% of the patients. If an SSRI is effective for the patient, but he or she is unwilling to cope with this, reduction of the dose, addition of bupropion or buspirion, or for men, a trial of Viagra may be helpful. Another complaint that is commonly reported in approximately 10% of the patients on SSRIs is weight gain. Abrupt SSRI continuation can lead to withdrawal characterized by flu-like symptoms. To avoid this, taper the drug dosage over a minimum of 2 weeks. Paroxetine is the drug most likely to provoke this response, and often the most difficult SSRI to have people taper down. Serotonin syndrome is potentially a lethal array of symptoms that are consistent with overactive stimulation of the CNS, and again can be caused by co-administration of drugs that increase serotonin. This usually appears within the first 24 hours and treated with discontinuation of the drug and supportive care. Serotonin and norepinephrine reuptake inhibitors are second line. Venlafaxine is a common second line. Medication is often used in patients who fail to respond to SSRIs. Nausea, dizziness, insomnia, sedation, and constipation are encountered commonly and may be transient, while some patients require a different agent when side effects persist. Hypertension is associated with this drug, and like paroxetine, is associated with significant withdrawal and often requires a taper over multiple months. This response seems to be dose-related and usually becomes a problem when the daily dose exceeds 300 milligrams, but may occur at doses as low as 75 to 150 milligrams. All patients should have their blood pressures measured at regular intervals because this effect may be seen later in therapy. Although it's used to treat anxiety, venlafaxine also has the side effects of increased anxiety. It's not considered as safe in overdose as the SSRIs. This venlafaxine is similar to this drug. It works via serotonin and norepinephrine reuptake inhibition. In addition to its use in major depression, it's been being studied for the use in pain syndromes associated with depression and in diabetic neuropathy with variable results. Common side effects are primarily GI, which includes nausea, dry mouth, and constipation. The FDA approved safety labeling revisions for duloxetine, delayed release capsules, which is Cymbalta, to emphasize that MAOI should not be used with or in close temporal proximity to the SSRIs or SNRIs. Use of serotonergic drugs can lead to serious and sometimes fatal drug interactions with Cymbalta. Symptoms may include hypothermia, rigidity, monoclonus, autonomic instability, and possible rapid fluctuation of vital signs and mental status changes that include extreme agitation, progressing to delirium, and coma. According to the FDA, these interactions have been reported in patients who initiate MAOI therapy following recent discontinuation of SSRIs or SNRIs. Some of these cases presented with features resembling neuroleptic malignant syndrome. There should be at least 14 days separating the use of the two drugs in the same patient. For the norepinephrine and dopamine reuptake blockers, bupropion is significantly different from other antidepressants. It's been shown to be a mild stimulant and has found a place among patients who present with fatigue and poor concentration. Also, bupropion lacks the side effects associated with sexual dysfunction and is a reasonable alternative to an SSRI. Its ability to alter dopamine activity in the nucleus accumbens or the so-called reward area of the brain is thought to account for its efficacy in smoking cessation. Bupropion has a very low risk of seizures, and the risk of seizures is higher in patients with a history of head trauma, prior seizures, CNS tumors, or eating disorders, or also taking medications that lower seizure, other medications that lower the seizure threshold. Headache and mild agitation are the most common side effects of this drug. For the tricyclic antidepressants, typically used as third-line agents, even though studies have shown equal efficacy in comparison with newer agents. Patients who are tolerating TCAs and have achieved a good clinical response should remain on them. Consider a TCA when cost is a factor. They are widely available in generic form and much less expensive than the SSRIs, even those available as generic agents. Their use has fallen in recent years with the development of significantly safer and better tolerated drugs, such as the SSRIs. Also, substantial risk of fatal overdose can occur with doses as low as 5 times the therapeutic dose. TCAs slow cardiac conduction, which may lead to heart block or arrhythmias. These agents are used in caution in patients who have pre-existing cardiac dysfunction, and a baseline EKG is recommended in patients older than 40. In addition, the QT interval should be monitored periodically. TCAs have found a niche in the treatment of patients with neuropathic pain syndromes, such as trigeminal neuralgia and diabetic neuropathy. The mechanism of action is thought to be caused by norepinephrine reuptake blockade. Amitriptyline is the TCA of first choice for pain relief, although other TCAs are also effective. The initial dose of TCA for neuropathic pain is 10 to 15 milligrams given at bedtime. You can increase the dosage by 10 to 25 milligrams every 2 to 3 days. Analgesic effects usually are evident within about 1 week after the effective dosage has been reached. Patients should be informed of this delay in analgesia effects because, again, most patients expect immediate results. For the alpha-2 noradrenergic antagonists, mixed serotonin blockers, side effects of mirtazapine include sedation, fatigue, increased appetite, and weight gain. Sexual dysfunction is much less with the SSRIs. An unusual finding is that the sedation associated is more common with patients who take lower doses, such as 15 milligrams, rather than the higher dose of 30 milligrams. It's very effective in alleviating depression while increasing appetite and eliminating insomnia. Anti-anxiety and sleep improvements are reported to occur as early as 1 week after the drug has been started, although full antidepressant response may take several weeks, as with other antidepressants. Its use in younger patients is limited by sedation as well as weight gain. Another consideration in drug selection is whether potential side effects might be beneficial for a particular patient. For example, in some nursing home residents who are underweight and have poor appetite, this could be a good choice because the weight gain is desirable. For the serotonin 2A antagonists and serotonin reuptake inhibitors, trazodone and nifazodone both are included in this class, but they have different mechanisms of action. Trazodone is has a short half-life and can only truly be used as an antidepressant when dosed BID or TID at high doses, and is seldom used as first-line agents for the management of depression because of the side effects of sedation, rare reports of cardiac arrhythmias, and priapism, which can be a medical emergency. For example, when dosed appropriately for depression, patients will sleep all day and all night. Initially, 150 milligrams per day should be given in divided doses and then increased by 50 milligrams per day every 3 to 4 days as needed. However, slower titration schedules may be better tolerated. Maximum daily dosage of 400 milligrams per day by mouth for outpatients and 600 milligrams per day for inpatients. Trazodone may have a role in treatment of patients with insomnia and may be used to augment drug therapy for patients who have a partial response but remain anxious. Nafoxidone, too, is seldom used in treatment for depression. 25 cases of liver failure and death have been reported since 1995. This may be even more. Close monitoring of liver transaminases, the AST and ALT, has not proved to be predictive of liver failure. Also, it has numerous drug-to-drug CYP3A4 interactions. It was withdrawn from the U.S. market in 2004, but generic versions are available. Nafoxazodone has a calming effect with less sedation than the TCAs. It may be helpful for patients with sleep disorders. It's uniquely associated with an increase in REM sleep versus the decrease associated with many other antidepressants. Sleep disorders and depressions are closely linked, and it's theorized that the sleep disorder may be a central part of the depression. Nafoxazodone may cause less sexual dysfunction than caused by other antidepressants. And finally, the MAOIs, the monoamine oxidase inhibitors, the broad spectrum of action is inevitably associated with a broad spectrum of adverse reactions, including hypertensive crisis, which can be fatal. A hypertensive crisis can occur within several hours after taking the substance, or after taking a substance that contains tyramine. Tyramine releases norepinephrine and other symptomatic amines, thereby raising blood pressure. Early symptoms include occipital headache, palpitations, stiff neck, nausea, vomiting, and sweating. Many medications, especially other antidepressants and foods that contain tyramine, can elicit this response. If suspected, the provider should refer the patient to the emergency department immediately. Any change in medication to or from an MAOI absolutely requires a washout period of at least 2 weeks. So how do we monitor and treat these patients? The patient should be seen weekly for the first few weeks to months until improvement is seen, then monthly until remission occurs, and periodically thereafter. Monitor for therapeutic effects as well as adverse reaction. The U.S. FDA requires that all antidepressants carry the black box warning for increased risk of suicide in children and adolescents with major depressive disorder or another psychiatric disorder, especially during the first months of treatment or at times of dose change. Despite this warning, new research examining data from 41 clinical trials of more than 9,000 adults and children showed that Paxil neither increased nor decreased suicidal thoughts or behavior in children. In adults, antidepressants was linked to the declined risk of suicidal thoughts and behavior. However, individual response is highly variable, and each and every patient, regardless of their age, requires vigilant monitoring. If the patient is suicidal, the chances that the patient will commit suicide successfully are highest during the first few months of a depressive disorder or episode, or shortly after an antidepressant is started. When medication starts to work, the patient may be energized just enough to follow through on a plan, as many plans may not require much energy. If TCAs are used, limit the quantity of medication prescribed and do not use the refill option to avoid giving the patient a method for suicide by drug overdose. This is usually not a risk with other antidepressants. Depressed patients often are prescribed more than one medication to treat the symptoms. However, data shows that the use of more than one antidepressant, and clearly the use of dual-acting antidepressants, is no more useful than the use of one antidepressant. There are significant drug-to-drug interactions among the antidepressant drugs, and you need to keep this in mind. For patient variables, geriatrics, elderly white men have the highest risk of suicide of all patients. Elderly patients are more vegetative and cognitive symptoms. Elderly patients have more vegetative and cognitive symptoms and fewer complaints of mood problems. Drug selection often is limited by medical conditions such as cardiac conditions and stroke. Dehydration may lead to toxicity from antidepressants even if low dosages are used. The elderly often have subclinical renal and hepatic dysfunction that will slow drug metabolism and excretion, raising these drug levels. This is why lower dosages usually are required. SSRIs have been assessed as producing more side effects in the elderly than the others. These side effects are both more frequent and less well tolerated, especially histaminic and anticholinergic effects. The elderly are more sensitive to the anticholinergic side effects of TCAs, such as orthostasis, sedation, and urinary retention. This can lead to falls and worsening of urination, especially in men with BPH. Falls can be a problem with any antidepressant in the frail elderly, but non-SSRI antidepressants such as bupropion or vaccine significantly increases the risk of falls in nursing home residents. Use of amitriptyline should be avoided in the elderly because of sensitivity to the anticholinergic side effects and cardiotoxicity. For pediatric patients and adolescents, TCAs are used in children older than 12 years old. SSRIs are used in patients older than 18, Paxil in those 8 years or older. Other medications are used in patients older than 18 years of age. Depression occurs in children and adolescents frequently. Presentation can be very difficult than in the adult, and it varies with age. Younger children have behavioral problems such as social withdrawal, aggressive behavior, apathy, sleep disruption, and weight loss. Adolescents exhibit somatic complaints, self-esteem problems, rebelliousness, poor performance in school, or risky or aggressive behavior. Risk of suicide is relatively high, especially when accompanied by alcohol or other substance abuse. The FDA requires that a black box warning be added to the labeling of commonly used antidepressants detailing the risk of suicide in pediatric patients. A causal role has been established for antidepressants, including suicidality in pediatric patients. There is also an increased risk of suicide thinking and behavior in young adults aged 18 to 24. Therefore, the clinical need for an antidepressant in children or young adults for any use must be weighed against the risk of increased suicide. Patients who are started on therapy should be observed closely for clinical worsening, suicidality, or unusual changes in behavior, particularly within the first few months of starting therapy or at the time of dose increase or decrease. Such observation would generally include at least weekly face-to-face contact with the patient during the first 4 weeks of treatment, and then every other week visits for the next 4 weeks, then at 12 weeks, and as indicated beyond 12 weeks. Additional contact by telephone may be appropriate between visits. It's unknown if suicide risk in children and young adults extends for longer-term therapy. Many of the manufacturing labels do have monitoring suggestions. It should be noted that psychiatric adverse effects of SSRIs overlap with manifestations of depression itself. Without knowledge of adverse effect, clinicians may make the mistake of increasing rather than decreasing the SSRI dose of children and adolescents who are experiencing these adverse effects. Treatment of a child or adolescent with recent onset of depression should begin with practical coping skills, family intervention, cognitive behavioral therapy, or other forms of psychosocial treatment. Patients with depression should be treated by a pediatric specialist. For those patients who are pregnant and lactating, the SSRIs other than Paxil, Vilaxifene, Trazodone, Nefezodone, Mirtazapine, Bupropion, Amitriptyline, and Desparamine are Category C. Imipramine and Nortriptyline are Category D. And for those who are lactating, all the antidepressants are present in breast milk. So these patients, risk versus benefits again. The risk of depression during pregnancy may involve suicide and impaired function, such as the lack of self-care, lack of care of the fetus, inability to care for their other children. Mild to moderate depression generally is treated with psychotherapy alone. The addition of an antidepressant is generally reserved for women with severe depression. The SSRIs, specifically Paxil and sertraline, generally are recommended because they have been studied most extensively and have shown a good safety record when used in pregnant and breastfeeding women. Fluoxetine has the advantage of long-term follow-up in infants who are exposed during pregnancy. Paroxetine carries a warning of fetal abnormalities and should not be used. Antidepressants use in pregnancy may raise autism risk, and there is confusing research about whether SSRIs increase the risk of persistent pulmonary hypertension in babies exposed to SSRIs in early pregnancy. Some research suggests that mothers who had SSRIs in early pregnancy had a slight increase, while those mothers who had SSRIs in late pregnancy had a twofold increased risk of having babies with persistent pulmonary hypertension. For gender, men often refuse to endure the sexual dysfunction that occurs with SSRIs, and they need to be forewarned. Cultural principles also come into effect. Culture may hamper diagnosis and hinder treatment. Many cultures do not recognize depression as an illness. The patient may have difficulty expressing his or her feelings, and depression may manifest as physical, somatic, and psychomotor symptoms. Language may be a barrier. Most patients prefer not to take medication, and it's important to find out what the condition is called in their culture and learn the causative explanation. If it is caused by evil spirits or by a frightening experience, it is unlikely that drugs will be an acceptable form of treatment. Also, many immigrants have experienced very stressful life situations, and perhaps culturally based support would be helpful, such as resources within their communities. Some African Americans may see depression as a in religious terms as lack of faith or punishment. For patient education, you need to ask about all other medications or herbs that the patient is taking. You need to ask about side effects and explain that they're seen within the first few doses, but usually resolve approximately 7 days after starting the medication. You need to explain that it may take 3 to 6 weeks before benefits are seen. Avoid alcohol and sedatives when taking the antidepressant. Explain that many antidepressants can cause sedation. Patients should avoid tasks that require alertness or coordination until they know how the medication will affect themselves. They need to notify primary care providers of any adverse effects, and if the patient intends to become pregnant or is breastfeeding. You can help suggest ways to minimize adverse effects of these drugs. You need to explain that a withdrawal symptom may be experienced if the antidepressant is discontinued abruptly, and notify patients of specific drug risks such as with the tricyclic antidepressants, higher risk for seizures and photosensitivity. For the SSRIs, patients develop rash, hives, or an allergic phenomenon, photosensitivity, and that they should swallow controlled release forms whole and not crush the tablets. And vaccine can cause rashes or hives, allergic phenomenon, and they too need to swallow controlled release forms whole. Trazodone needs to be taken with food. Priapism in males may occur. Nefazodone can cause liver abnormalities, can cause death, rash, hives, allergic phenomena, visual disturbances, photosensitivity. Mirtazapine can cause agranulocytosis, and the patient needs to notify their care provider if symptoms of infection occur. So now we'll move on to anti-anxiety and anti-insomnia agents. We touched a little during our last section, but this class includes the anti-anxiety, the buspirone, anti-anxiety and anti-insomnia agents such as benzodiazepines, insomnia such as the GABA BZ receptor antagonists and the melatonin receptor antagonists as well. So for the benzodiazepines, which many of us are familiar with, they act by potentiating the action of the GABA, which is an amino acid and an inhibitory neurotransmitter, and this results in increased neuroinhibition and CNS depression. Benzodiazepines bind to specific benzodiazepine receptor sites, the BZ1, BZ2s. The BZ1 is involved in sleep. The BZ2 is involved in memory, motor, sensory, and cognitive function. The BZ receptor is a ligand-gated C1 channel, and the GABA activation of the receptor sites in inward flow of C1, which causes increased neural inhibition and CNS depression. The BZ1 to BZ6 refers to distinct receptor subtypes and not simply to binding sites on the same receptor molecule. Inhibition of the benzodiazepine receptors in the spinal cord causes muscle relaxation. In the brainstem, it acts as an anticonvulsant. In the cerebellum, it causes ataxia. And in the limbic and cortical area, it affects emotional behavior. Anti-anxiety effects are distinct from the non-specific consequences of CNS depression, such as sedation or motor impairment. Benzodiazepines act as a sedative hypnotic by acting on the limbic system and the subcortical CNS. They shorten REM sleep and stage 4 sleep, but increase total sleep time. These medications have high abuse potential because they're so widely available. Clonazepine, diazepam, and clorazepate suppress neural discharges in the patient during seizures. Seizure activity is inhibited by depressing nerve transmission in the motor cortex and suppressing the spike and wave discharge in absent seizures. Clonazepam has high potency and increased efficacy against absent seizures. Buspirone lacks the BZ effect. The onset and duration of benzodiazepines are variable. Triazolam and midazolam are considered short-acting. Alprazolam, lorazepam, oxypam, and temazepam are longer-acting. For buspirone, the exact mechanism of action is unknown. It is not chemically related to the benzodiazepines, the barbiturates, or any anti-anxiety agents. Buspirone lacks a BZ effect. It has a high affinity for serotonin receptors and a lesser affinity for dopamine receptors. It does not have muscle relaxation or anticonvulsant properties and is non-sedating. The anti-anxiety effect is achieved via a partial agonist effect on CNS serotonin 5-HT1A receptors that occurs without affecting the benzodiazepine receptors or causing CNS depression. Downregulation of postsynaptic 5-HT2 receptor is also possible. For the GABA BZ agonists, the chemical structure is dissimilar from those of the benzodiazepines and other sedative hypnotics. These agents appear to act through the potentiation of GABA on benzodiazepine receptors, especially the omega-1 subunit. They are used primarily for sedation. They have exhibited some anti-anxiety action, but they have little effect on skeletal muscle or seizure thresholds. They appear to have minimal disruptive action on the normal sleep cycle, thus preserving deep sleep in stages 3 and 4. They have shown no potential for causing addiction. However, because they affect the benzodiazepine receptors, the potential for dependence is a matter of concern. Ramelteon is a melatonin receptor agonist with affinity for the melatonin receptors MT1 and MT2. The MT1 and MT2 receptors are acted upon by endogenous melatonin and are thought to be involved in maintenance of normal sleep-wake cycles. This action occurs in the subarachnoid nucleus of the brain, which is the regulation center for circadian rhythms. Ramelteon has no affinity for the GABA-BZ receptor complex. So what are the cardinal points of treatment for anxiety? Patient needs education as well as psychotherapy. For generalized disorders, acute treatment is benzodiazepines. Long-term is SSRIs. For panic disorders, acute treatment includes benzodiazepines. Long-term treatment includes SSRIs. For phobic disorders, acute treatment includes beta blockers or benzodiazepines. For long-term treatment, SSRIs, MAOIs, or gabapentin. For OCD, SSRIs, fluvoxamine, and TCA, clomipramine, and buspirone. For PTSD, SSRIs, TCAs, and MAOIs are useful. Patients must be reassured that they are not the victims of a terrible disease, that they can control the anxiety, and relaxation techniques and breathing exercise can be useful and may be taught by you as the provider. Meditation can also be helpful. Psychotherapy is an important component of the treatment provided for anxiety disorders and should be considered for every patient. Brief counseling sessions of 20 to 30 minutes have been shown to provide significant benefit. Historically, pharmacologic treatment of generalized anxiety disorders has employed the TCAs and benzodiazepines as first-line agents. However, side effects, abuse potential, and tolerance, particularly to the TCAs, have curtailed their use over the years. Recently, the SSRIs have proved effective for generalized anxiety disorders with minimal side effect profiles, and many providers have opted to use them as frontline agents. Several SSRIs have been shown to be effective for generalized anxiety disorders in clinical trials, although only a few have formal indications. The selection of the SSRI depends largely on side effect profile and cost. It's preferable to avoid those agents that have high incidences of insomnia and restlessness, because these are often the subject of complaints expressed of the patients with a generalized anxiety disorder. These excitatory side effects are sometimes unavoidable with the SSRIs. Therefore, it's suggested the starting doses should be approximately 50% of those used for treatment with depression. It's frequently necessary to combine benzodiazepines with antidepressants in the treatment of generalized anxiety disorder. A benzodiazepine should be used only on a short-term basis and should be tapered approximately 10% per week once the antidepressant has reached its peak effect, usually after 6 to 8 weeks. Short-acting benzodiazepines are particularly difficult to discontinue because anxiety symptoms recur quickly, and this makes it difficult for patients to stop them. A longer-acting drug such as lorazepam or clonazepam is preferred. Symptoms of withdrawal normally begin to disappear within 2 weeks of a dose reduction. This can help the provider distinguish between breakthrough generalized anxiety disorder symptoms and benzodiazepine withdrawal. These drugs have a much higher potential for abuse in patients with a history of alcohol or drug abuse and should be avoided in this population. However, this is difficult because a lot of the patients in this population have generalized anxiety disorder. Buspirone may be a good alternative for these patients because it lacks the potential for abuse. However, GI side effects are common, and therapeutic effects may not be seen for up to 8 weeks. The benzodiazepines may cause retrograde amnesia that will interfere with the patient's ability to learn adaptive behavior, sometimes limiting the benefit of the psychotherapy. The SSRIs are considered the drugs of choice for treatment of panic disorder. Low initial doses and slow titration are recommended to avoid the excitatory side effects of the SSRIs. The provider must counsel the patient that symptom relief may take 4 to 6 weeks. The Vaxin and the SSRI reduced the severity of symptoms, but does not substantially enhance patients' quality of life in one study. TCAs are as effective as the SSRIs, but bothersome side effects and increased drug interactions limit their acceptability. If a TCA is used, nortriptyline is suggested because of the relatively low incidence of side effects compared with other TCAs. Low doses and slow titrations is necessary. Phobic disorders usually are treated according to the specific type of phobia. Specific phobias are best managed with cognitive behavioral therapy and occasionally with short-term use of beta blockers and benzodiazepines. The SSRIs and benzodiazepines were found to be the most effective in treatment of social phobias in one meta-analysis. Clonazepam demonstrated a 78% response rate after 10 weeks in therapy in one trial versus 20% in patients in the placebo group. TCAs, however, have not been shown to be effective for social phobias. Patients with agoraphobia are treated in the same manner as those with panic disorders. OCD has been treated effectively for many years with a TCA with serotonin selective properties, clomipromine. In addition to 5-HT, clomipromine inhibits norepinephrine reuptake via an active metabolite, desmethylclomiprane. chlorperamine. After 10 weeks of therapy, a mean reduction of 38 to 44% in OCD scores was reported in 2 separate studies of more than 500 patients. Placebo-treated patients reported mean reductions of only 3 to 5%. The SSRIs have been used for OCD and have proved equally effective. The vaccine has shown efficacy comparable with that of paroxetine in a small trial. Several agents are used in the management of PTSD. SSRIs were considered first-line medications. These drugs reduce both positive and negative symptoms of PTSD, although the greatest benefit appears to result from a reduction in positive symptoms. Fluoxetine, sertraline, and paroxetine have been used for moderate to severe PTSD. TCAs usually are considered second-line medications. They've been shown to improve positive symptoms such as intrusive nightmares and flashbacks, but not as effective in reducing negative symptoms such as numbing and withdrawal. Anti-anxiety agents have not proved particularly useful for the management of PTSD, despite the prevalence of enhanced startle reaction and jitteriness in these patients. Patients who show little or no response to the antidepressants may be candidates for antipsychotic medications such as olanzapine and aripiprazole. So what are the cardinal points of treatment for insomnia? Sleep hygiene is very important. Finding the cause of insomnia is key to solving the problem. For short-term insomnia, the GABA BZ agonists, benzodiazepines are useful. For long-term insomnia, Ramelteon, GABA BZ agonists, and trazodone are not indicated but are often used. Low-dose doxepin is now approved for chronic sleep maintenance. Treatment for patients with insomnia begins with sleep hygiene. It's important that the patient follow the regimen. The patient must have responsible expectations, and overcoming insomnia is a gradual process with no overnight success. One can move up the time of onset of sleep only by 15 minutes every 3 to 4 days. Sleep hygiene involves developing a regular bedtime with lights out or dimmed, develop a regular waking time and avoid sleeping longer than usual, adjust the total sleep time to fit the patient's needs, avoid routine daytime naps, exercise regularly but not within 1 hour of bedtime, sleep in a cool room, avoid alcohol 3 to 4 hours before bedtime, avoid stimulants such as caffeine 8 hours before bedtime, avoid stressful topics, arguments before bedtime, try a warm bath, try warm milk, use bed only for sleeping and making love, avoid reading and watching TV in the bed, learn and practice relaxation techniques. If these measures are ineffective, a medication may be considered. It should be used in conjunction with sleep hygiene program and should be given for a limited time to help the patient reestablish a regular sleep pattern. These medications usually move up sleep onset by 10 to 30 minutes and increase total sleep by 20 to 40 minutes. Although the practitioner may not think this signifies much progress, the benefit perceived by the patient is substantial. Benzodiazepines have been used for many years for the short-term treatment of insomnia. If used properly, they are safe and effective and are less expensive than the GABA BZ agonists. Many patients become dependent on benzodiazepines to fall asleep, and withdrawal can be difficult. Benzodiazepines must be used for a limited time and only to treat appropriate sleep disorders. Benzodiazepines are contraindicated in patients who have sleep apnea and the use of other hyperinsomnias. The GABA BZ agonists are used frequently for the short-term treatment of insomnia. Zolpidem is used for the patients who have problems with both sleep onset and maintenance. Lower strengths are used for people who have trouble returning to sleep after wakening in the middle of the night. Zolpidem is more useful for onset insomnia, especially in patients who have occasional difficulty falling asleep because of the time zone change or a stressful event. It comes in extended release as well. Azopiclone is useful for sleep maintenance and was approved for long-term use for up to 6 months. The others are approved only for short-term use, 35 days, but are frequently used for longer periods of time. Ramipril is a melatonin that is approved for chronic insomnia. Its use is not limited. However, it's not as effective as the GABA-BZ insomnia drugs. Again, sleep hygiene remains a mainstay of treatment. Benzodiazepines and the GABA-BZ agonists are useful for short-term insomnia. Trazodone, an antidepressant with sedative effects, may be used if other therapies are not effective. All insomnia medications except Ritalin have an increased risk of the patient engaging in activities while somnolent with no memory of having taken the pill. The FDA has required manufacturers to label products with this risk and to develop patient information to warn patients of this problem. Really, they also may cause anaphylaxis and angioedema. For patient variables, geriatric patients, elderly, debilitated patients, and those who have impaired liver and renal function require dosing reduction and cautious monitoring. It increases the risk of falls, over sedation, and ataxia. The use of any CNS agent in the elderly increases these risks. When it's necessary to use a benzodiazepine in an elderly patient, the lowest dose of a short-acting drug is tolerated best. The non-benzodiazepines are generally preferred. Because of the risks associated with polypharmacy, the practitioner must examine all medications for the possibility of drug interactions. For pediatrics, the safety and efficacy of risperidone, zolpidem, and in children younger than 18 years of age has not been established. Some medications are, for different ages, greater than 6 years, greater than 9 years, greater than 6 months, greater than 12 years, and greater than 18 years. You need to make sure that the medications that you're prescribing are to be suitable for those age groups. For pregnancy and lactation, category B, for risperidone, breastfeeding should be avoided. C and D for the rest. Benzodiazepines can cause fetal damage and are excreted in breast milk. Thus, they are considered category D and X. And barbiturates are found to cause fetal abnormalities when given during pregnancy. Women of childbearing age should be cautioned to use effective contraception when taking benzodiazepines or barbiturates. Treatment principles and education. Many medications belong to the benzodiazepines class. Diazepam is the prototype and was the first. This is also called Valium. The benzodiazepines share a common mechanism of action and generally have similar therapeutic effects and adverse reactions. Benzodiazepines have been shown some significant risk for causing psychologic and physiologic dependency and are used only on a short-term basis. Specific benzodiazepine used for insomnia includes tempazepam, clorazepam, trazodone, and lorazepam. The maximum therapeutic effect may take 1 to 2 weeks to achieve, and tolerance develops in 6 to 8 weeks. Benzodiazepines must be tapered gradually to minimize the risk of withdrawal, and patients who have a history of addiction, depression, and psychosis are not good candidates for the use of the benzodiazepines. Avoid fluorazepam in the elderly because of its long-acting metabolite, which greatly increases the risk of falls from oversedation. How to monitor for benzodiazepines: order periodic laboratory work to monitor liver and renal function, CBC, and urinalysis. Monitor side effects such as dizziness, hangover effect, daytime sleepiness, ataxia, and slurred speech. Monitor for signs of dependence such as increased requests for medication or increased refills or prescriptions. Perform a routine review of all medications, including over-the-counter medications, before prescribing at each visit. Specifically for buspirone, monitor for dizziness. Zolpidem, monitor for dizziness and headache. For benzodiazepine, again, may cause drowsiness, dizziness, and fatigue, and should be used with caution when driving or operating machinery that requires alert mental status. Do not use with alcoholic beverages or CNS depressants. Dependency can be a problem. The patient should not stop the medication suddenly. Withdrawal symptoms such as sweating, vomiting, muscle cramps, tremors, and seizures may occur. Dosage must be reduced gradually under the supervision of a practitioner. The patient should be told not to take any medications, including over-the-counter preparations, without talking to their provider, and report any tremors, seizures, ataxia, dizziness, difficulty breathing, and chest tightness. The patient should be told to rise slowly from a lying or sitting position because orthostatic hypotension can be caused by the medication and result in dizziness as well as falls. Similar to the medications we've been talking about, we'll move on to the antipsychotics. The antipsychotics, also known as major tranquilizers or neuroleptics, are used commonly in the treatment of a variety of psychotic disorders. Their use in schizophrenia in the management of behavioral and psychological symptoms is its mainstay. Primary care providers offer general or acute care for patients who may be taking these antipsychotic drugs. However, usually are not prescribed by their primary care physicians. These are specialty drugs, and providers who prescribe these drugs routinely will require prescribing information with much greater detail. Providers who see geriatric patients, especially in the hospital or in nursing care facilities, should be prepared to be familiar with this category of drugs, and will need more detailed information than a general course will provide. There's growing documentation of prescribing off-label antipsychotic drugs, particularly in nursing homes, to calm patients with dementia. Has been considered. Medicare has threatened to institute penalties for the use of antipsychotic drugs, and research has showed or suggests that antipsychotic medications are overprescribed in older demented patient population. The use of these medications off-label, particularly for treating insomnia in patients with no psychotic disorders, is also under current criticism and is not standard practice. The first antipsychotic medication on the market, chlorpromazine, was introduced in the early 1950s. This is the key drug among the phenothiazines, first-generation antipsychotic agents. Currently, the antipsychotics are divided into 2 generations. The first includes the older typical drugs that treat the positive but not the negative symptoms associated with a psychotic state. Second-generation drugs have far fewer extrapyramidal symptoms and tardive dyskinesia, and they are used to treat both positive and negative symptoms of schizophrenia. With the exception of risperidone, they are prolactin sparing. So the first generations include the phenothiazines, and the list is here. The second generation include the dibenzapines, benzoazoles, and quinolones. These are used for the management of psychotic disorders, antiemetics, as well as management of bipolar disorders, conduct disorders, and tetanus. Some of the antiemetics, specific drugs such as Thorazine, has been used in conduct disorders in children, bipolar affective disorder, hiccups, intractable mania, nausea, porphyria, acute intermittent vomiting, tetanus adjunct. Chlorpromazine is used for generalized anxiety disorders, nausea, and vomiting. Some of the other medications include haloperidol, used in conduct disorders in children, Tourette's syndrome, psychosis in the intensive care unit, as well as delirium. Clozapine, used in schizoaffective disorder to decrease the risk of chronic suicidality. Risperidone is used for bipolar disorder, mania, psychosis. And there's a whole list of, Zyprexa, risperidol for acute manic episodes and mood stabilizers. There's also many unlabeled uses, such as behavioral psychologic symptoms of dementia, often use Thorazine and Haldol, parental antipsychotics for combative patients or other serious manifestations of acute psychosis. Some of these medications, again, for the control of severe nausea and vomiting. Thorazine is also been used for migraine. Some of the medications have been used for migraine headaches. Risperidone used for chronic tic syndrome, Tourette syndrome. Some have been used for autism. There's many different uses and many different drugs out there. It's important to understand that psychosis is not a disease. It's a term that's used to describe a general symptom complex in which gross impairment of reality is demonstrated. It has many causes, both organic and psychiatric. Psychiatrists usually treat the psychosis. A large number of diverse and even common medications can cause psychotic symptoms. It's difficult to talk about treating the general symptoms of psychosis. It is more productive to talk about specific psychotic disorders such as schizophrenia. Many elderly patients are particularly vulnerable to the development of psychotic symptoms. The combination of medical disorders, psychiatric disorders, and medications easily provoke psychotic symptoms, particularly when patients move from an unfamiliar environment to a strange setting, or when change disturbs a balance they are maintaining while coping with medical or psychiatric problems. Geriatric patients with dementia may exhibit behavioral or psychological symptoms which may or may not represent psychosis. These symptoms commonly include agitation, physical aggression, delusions, and hallucinations. Other behaviors such as refusing personal care, being unable to communicate or perform activities of daily living, wandering, being restless, and participating in self-destructive acts may require the use of some of these medications, sometimes only for brief intervals. Research has demonstrated that risk of developing metabolic syndrome in children and adolescents increases sharply after 3 to 12 months of antipsychotic treatment. The exact mechanism of the antipsychotic action is unknown. These drugs are thought to work by blocking postsynaptic dopamine receptors in the hypothalamus, basal ganglia, limbic system, brainstem, and medulla, and some extent serotonin receptors. Much work has been done to elucidate which receptors each drug affects. How this receptor blocking causes specific changes in behavior and cognition is unknown. Each neurotransmitter is associated with specific side effects. However, the correlation between the two is not completely understood. A very complicated and overlapping set of mechanisms interact to produce a wide variety of effects. Other complication is that the drugs produce different effects from patient to patient. Most cause sedation in some patients and agitation in others. Some antipsychotic drugs can cause metabolic side effects such as obesity and diabetes by activating the SMAD3 protein, which plays a role in the transforming growth factor beta pathway. This is a cellular mechanism responsible for inflammation and insulin signaling, among other processes. The first generation typical antipsychotic drugs are more potent antagonists of D2 dopamine receptors than the D1 receptors. They exhibit varying degrees of selectivity among the dopamine tracks. They also have effect on cholinergic, alpha-1, adrenergic, and histaminic receptors. Typical first-generation antipsychotics may be classified as high or low potency. Low potency, the typical antipsychotic drugs have a relatively small effect on dopamine receptors, but are potent antagonists of muscarinic or alpha-adrenergic and histamine 1 receptors, resulting in side effects such as dry mouth, constipation, orthostatic hypotension, and sedation. High-potency antipsychotics have a greater effect on dopamine receptors, causing a larger number of EPS than are produced in low-potency drugs. However, they exhibit few muscarinic, alpha-adrenergic, and histaminic effects. Although exceptions are noted, in general, high-potency drugs tend to elicit fewer cardiac, sedative, seizure-promoting, and skin reactions. High-potency drugs may tend to cause diarrhea, whereas low-potency drugs may tend to result in constipation. Drugs that affect the dopamine D2 receptors act as inhibitors of the synthesis and release of prolactin, thereby causing hyperprolactemia. However, the correlation between the drug's effects on the D2 receptor and the frequency of their causing galactorrhea is imperfect. The second generation, newer or atypical antipsychotic agents affect different receptor sites compared with the first generation antipsychotics. They bind dopamine, including the D1, D2, D4, and D5 receptors, with selectivity for limbic dopamine receptors. They have an increased affinity for serotonin receptors compared to the D2. In addition, they bind acetylcholine to alpha-adrenergic receptors, as well as muscarinic, histamine 1, and nicotinic receptors. They exhibit reduced ability or an inability to induce EPS. The FDA has required that manufacturers add a warning to the product information about these drugs regarding incidences of hyperglycemia, obesity, and diabetes mellitus that is seen in patients who take second-generation drugs. Aripiprazole is the first of a new class of atypical antipsychotic agents called dopamine system stabilizers or dopamine partial agonists. It combines the actions of D2 and serotonin 5-HT2A receptor antagonisms. The FDA has issued a warning about the possible severe allergic reaction, including anaphylaxis and angioedema, to this drug. Clozapine is specific for limbic receptors and not for striated muscle receptors, which explains the low incidence of EPS and tardive dyskinesia. For the cardinal points of treatment for the acute phase, initiate pharmacological treatment promptly as long as it does not interfere with the diagnostic testing. Determine the patient's response, what the patient's response has been to other antipsychotic medications that he may have taken and which side effects he has experienced, if any. Begin antipsychotics at a low dose and titrate up slowly over the course of several weeks. As necessary, do not exceed the dose at which EPS are likely to occur. Provide adjunctive medications depending on comorbid conditions. These include benzodiazepines, antidepressants, mood stabilizers, and beta blockers. For the stable phase, the purpose of the medication is to prevent relapse. Do not decrease the dose of medication to limit EPS if this also causes a relapse of symptoms. For psychosis, typical and atypical antipsychotic drugs have been shown to be equally efficacious. However, atypical antipsychotics generally are preferred as first-line agents for long-term treatment because of the relative lack of extrapyramidal EPS signs in tardive dyskinesia, but an increased risk of development of diabetes. Each patient will respond differently to the therapeutic adverse effects of these drugs. There is little basis for choosing one drug over the other on the basis of target symptoms. Response or lack of response to one drug does not predict response to another. Therapeutic effect is measured by the patient's improvement in functional abilities and reduction in psychotic symptoms. Generally, it takes 3 weeks to achieve the full therapeutic benefit of antipsychotic drugs. Even with initially responsive patients, relapse is possible because of drug intolerance, physical illness, comorbid conditions, or changing life circumstances. Because of the side effects, non-adherence is a big issue with almost any antipsychotic medication. Gradually increase dose to achieve therapeutic effect while minimizing side effects. Once the therapeutic effect has been established, attempt to decrease the dosage for long-term maintenance. Allow sufficient time between dosage adjustments to assess effectiveness, and guidelines do not suggest drug holidays because these were not effective in minimizing the development of tardive dyskinesia. The formulation used is frequently determined by the patient's willingness to take the medication. If the patient is not willing, it may be necessary to give the medication as a colorless, odorless liquid mixed with a beverage or as an IM injection. These are for the patients who are at risk for hurting themselves or others. Once the medication reaches therapeutic levels, it then may be possible to switch to an oral tablet formulation. Depot preparations are administered by injection, may be effective up to 4 weeks, and are useful for the long-term treatment of a patient who is unwilling to take daily oral medications. First-generation antipsychotics tend to have a greater effect in decreasing positive symptoms, with negative symptoms tending to be more chronic and refractory in nature. Second-generation agents may be more effective against negative symptoms. Trends in psychotropic use for chronic conditions lean towards the use of second-generation drugs. First-generation drugs are available in generic form and are significantly less expensive than the newer drugs. Many drugs are currently under development. Non-pharmacological treatment is recommended as the initial approach. The American Psychological Association guidelines suggest that the provider's action should be directed towards preventing harm, controlling destructive behavior, reducing the severity of psychosis-associated symptoms, identifying the trigger for psychotic symptoms, effecting a rapid return to best levels, and developing family relationships to find the best aftercare solution. The patient should be closely evaluated for suicidal potentials during this phase. An accurate diagnosis of what causes the psychotic episode is important. Use of psychotropics in geriatric dementia is common, but they do not have FDA approval. Risperidone and olanzapine increase risk of the development of heart disease and stroke and should be used cautiously. For the pharmacological treatment, again, antipsychotic drugs are useful in treating many psychotic symptoms. For short-term treatment of an aggressive, dangerous patient or a geriatric patient with delirium or dementia with agitation, Haldol or chlorpromazine can be used IM with the results noted in 15 to 20 minutes. Use 1 milligram of Haldol for geriatric patients and 2 to 5 milligrams for young adults. The dose may be repeated in 20 minutes. The atypical antipsychotic risperidone may be used for the treatment of acute aggressive behavior. Antipsychotics are useful in treating some psychiatric symptoms of dementia, including agitation, hyperactivity, hallucinations, suspiciousness, hostility, and uncooperativeness. They have done much to improve the quality of life in some demented patients. However, they do not improve memory loss and may impair cognitive function. As always, use the lowest dose for the shortest possible duration. Although the use of antipsychotics in geriatric patients with dementia is common practice, these drugs, again, are not FDA approved. Studies using risperidone have shown increased risk of heart disease and stroke in the elderly, leading the manufacturers to declare that they are not safe and effective in the elderly population. All antipsychotics currently carry black box warnings about this potential problem. Whether this problem can be generalized to other antipsychotics and how these study findings should affect clinical practice is not really known at this time. Second-generation antipsychotics frequently are used to decrease the occurrence of EPS symptoms, but EPS still frequently occurs, with the exception of Clozaril. Monitoring these patients. Monitor liver function, CBC, for blood dyscrasias, and cholesterol. The frequency of monitoring depends on the drug used and other comorbid conditions that may exist. For clozapine, monitor weekly CBCs with differential. The manufacturer maintains a confidential register. Patients must be enrolled, have a baseline white blood count and absolute neutrophil count before initiation of therapy. Treatment should not be initiated if the baseline white blood count is less than 3,500 millimeters cubed, or ANC is 2,000 millimeters cubed. Issues of weekly supplies of the drug is dependent on the results of the weekly blood cell count. The results are sent to a national registry via forms supplied by the manufacturer. If after 6 months of weekly monitoring the white blood count has continuously remained greater than 3,500 and the ANC has remained greater than 2,000, then monitoring of blood counts through the registry may be reduced to every 2 weeks for 6 months. If acceptable white blood counts and ANC counts have been maintained during the second 6 months of continuous therapy, white blood counts and ANC may be monitored every 4 weeks, starting at the end of 12 months and thereafter. As you can see, this is laid out very clearly, and the manufacturer does maintain this confidential register. You need to assess for extrapyramidal symptoms at each patient encounter. Use of an abnormal involuntary movement scale is recommended. You must monitor blood glucose monthly for the onset of diabetes mellitus, and follow weight changes and evaluate weight loss or weight gain trends, as almost all antipsychotics are tied to weight gain and insulin resistance, particularly in children. For patient education, you need to explain that hypotensive effects may be experienced during the titration of dose. They need to use caution when driving or operating dangerous machinery because of drowsiness that may be caused by the drug. Inform the patient of the risk of EPS, including irreversible tardive dyskinesia. Use sunscreen and wear hats or protective clothing to avoid sunburn, rashes, and skin pigmentation, because some antipsychotics carry labels that indicate that products may increase skin pigmentation and photosensitivity. If the patients experience dry mouth, encourage them to drink more fluids, chew gum, or suck on hard candy. Immediately wash off any medication, especially the liquid concentrate, spilled on the skin to avoid contact dermatitis. Smoking increases the metabolism of antipsychotic drugs and may require a dosage adjustment. Patients should avoid alcohol when taking antipsychotics because it potentiates drug effects and may lead to symptoms of overdosage. Advise the patient to take missed doses only if remembered within 1 hour after the time the dose was due. They should consult the provider if the patient takes any over-the-counter medications concurrently with the antipsychotic drugs, and they should take the antipsychotics with food, juice, or milk to decrease the experience of GI upset. The patient should not take antacids within 1 hour after the antipsychotic drug is taken because this may interfere with drug metabolism. For extrapyramidal symptoms, although the antipsychotic drugs often are effective, almost all are associated with adverse effects. The most important adverse effects associated with antipsychotic drugs include EPS, some of which may be irreversible. EPS includes Parkinsonian syndrome, dystonia, neuroleptic malignant syndrome, and tardive dyskinesia. Tardive dyskinesia, or the abnormal involuntary movements, may be progressive and irreversible even after the drug is discontinued. It is characterized by rhythmic involuntary movement of the tongue, face, mouth, or jaw, protrusion of the tongue, puffing of cheeks, puckering of the mouth, chewing movements. These may be accompanied by involuntary movements of the extremities. Tardive dyskinesia has been the major limitation of first-generation antipsychotics because of the symptoms, and they can be disabling, preventing the patient from returning to society even after schizophrenia is controlled. Neuroleptic malignant syndrome, symptoms usually occur weeks after initiation of the treatment with antipsychotics. If this is an idiosyncratic reaction to the antipsychotic or neuroleptic drug, symptoms typically develop over a period of hours to days, and the condition is life-threatening. Major symptoms include fever, catatonic stupor, muscle rigidity, autonomic instability, tachycardia, delirium, and myoglobinemia. Parkinsonian symptoms typically occur more commonly in the elderly and with higher potency antipsychotics, except risperidone. Symptoms include masked faces, tremor, bradykinesia, rigidity, cogwheeling, drooling, and festination. Akasia may be difficult to differentiate from anxiety because the two appear to be so similar. Symptoms include an intensely unpleasant need to move, restlessness, and agitation. Because of the discomfort that is felt, it's often a big factor in non-compliance regarding medications. Acute dystonia symptoms include muscular rigidity, usually of the tongue, neck, face, or trunk. It's most likely to occur within the first week of antipsychotic drug therapy. Acute dystonia can be frightening, extremely uncomfortable, and life-threatening if laryngeal dystonia occurs. For the patient variables, geriatric patients, elderly patients have slower hepatic metabolism and increased sensitivity to dopamine antagonism. This makes them susceptible to extrapyramidal symptoms. Lower doses of antipsychotic drugs should be used. In general, use one quarter of the normal dosage. Longer waiting periods should be used before doses are increased to achieve therapeutic levels. The newer antipsychotics have been used with good results. For pediatrics in general, the antipsychotics are not recommended for children younger than 12 years old. There is sufficient evidence for the comparative advantages and disadvantages of using antipsychotics among children and young adults. However, researchers have reported evidence of moderate strength on the comparative effects of some second-generation antipsychotics. Some have caused more dyslipidemia and weight gain than risperidone, but fewer prolactin-related effects. Compared with placebo, second-generation antipsychotics improve clinical global impressions in schizophrenia, bipolar, and disruptive behavior disorders. Diminished positive and negative symptoms of schizophrenia, diminished behavior symptoms in disruptive behaviors, and decreased tics and Tourette syndrome. Antipsychotic drugs for use in children younger than 12 include chlorpromazine, thiodazine, low-potency trifluoroprozine, chlorpromazine, and haloperidol. Chlorpromazine should not be used in children younger than 6 months of age, except when it's potentially life-saving. Chlorpromazine should not be used in pediatric patients who weigh less than 20 pounds and those younger than 2 years of age. Thiodazine may be used in children older than 2 years. Antipsychotic drugs should be used only for the treatment of acute psychosis or explosive hyperexcitability behavior. Low doses should be used with long waiting periods before doses are increased to achieve therapeutic effects. Children who are prone to developing EPS tend to metabolize these drugs more quickly than adults do and should be used with caution. For those pregnancy and lactating, antipsychotic drugs should be avoided during pregnancy, especially during the first trimester because significant levels of these medications are found in both fetus and amniotic fluid. The causes of birth defects is unclear. However, infants have been born with EPS when antipsychotic drugs were administered to severely psychotic pregnant mothers. Breastfeeding should be discouraged because of the risks involved. One drug, clozapine, has been considered category B, and most of the first and second generation antipsychotics are considered category C. For race and gender, current research has not shown that any particular race has derived greater benefit than other from the use of antipsychotic drugs. No differences in side effects or adverse effects have been documented, although elderly African American women appear to be at greater risk for tardive dyskinesia. It has been found that young men less than 40 years and elderly women are at increased risk for development of EPS, especially acute dystonia. Drug therapy should be approached cautiously and monitored carefully, especially for those patients placed on antipsychotic drugs. And finally, our last topic in this session will be a quick review on substance abuse. Alcohol use disorders. Treatment often involves benzodiazepines for withdrawal, naltrexone for opiate as an opiate antagonist, decreases the intake, craving, Y-aminobutyric acid analogs, and disulfiram, which is an aversive agent. For opiate use disorders, opioid antagonists for overdose, naloxone for blocking, naltrexone for agonists, withdrawal, maintenance, methadone, and opiate partial agonists for withdrawal maintenance includes buprenorphine. Unlabeled uses for alcohol withdrawal and craving, carbenzapine, and for dependence, Chantix. There's beginning studies on the use of Chantix, which is currently approved only for smoking cessation. The indications for alcohol use disorders, again, the benzos, the naltrexones, disulfiram, and opioids use disorders, naloxone, naltrexone, methadone, and buprenorphine. Alcohol withdrawal, mild symptoms include anxiety, decreased mental function, tremor, depression, insomnia. Delirium tremors is an acute organic psychosis that occurs with mental confusion, tremor, sensory hyperacuity, visual hallucinations, atomic hyperactivity, diaphoresis, tachycardia, or seizures. Withdrawal often occurs when a patient is removed from home to the hospital or nursing home. Seizures occur within the first 48 hours, more likely when alcohol dependence is present. Hallucinations, visual, auditory, and tactile, commonly occur 12 to 72 hours after the last drink. DTs usually occur about 48 to 96 hours after the last drink. Mechanism of action, and effects of alcohol treatment. For alcohol withdrawal treatment, benzodiazepines demonstrate cross-tolerance with alcohol via GABA receptors. Long-acting benzodiazepines, such as diazepam or chlordiazepoxide, generally are preferred to minimize the occurrence of breakthrough agitation and seizures. Short-acting drugs, such as lorazepam and oxypam, are used in patients with severe liver disease. Naltrexone is an opioid agonist with highest affinity for the mu opioid receptor. Occupation of opioid receptors by naltrexone may block the effects of endogenous opioid peptides. The neurobiologic mechanism responsible for the reduction in alcohol consumption observed in alcohol-dependent patients treated with naltrexone is not entirely understood. However, involvement of the endogenous opioid system probably has its effect on alcohol consumption. Naltrexone has some effect on cravings for alcohol. It does not cause the physical adverse effects that are produced by disulfiram. Naltrexone blocks opioid receptors that are involved in the rewarding effects of drinking alcohol, and the cravings after abstinence is established. Acamprosate is structurally related to GABA agonists and potentiates the inhibitory effects of the GABAergic system. Patients with alcohol dependence notably display an imbalance of GABA and glutamate neurotransmission, which may be restored by this drug. The agent decreases glutamatergic transmission and modulates neuron hyperexcitability during withdrawal from alcohol. It reduces voluntary intake of alcohol but does not cause a disulfiram-like reaction. This drug is possibly helpful with regenerating neurotransmitters and restoring the balance between GABA and glutamate when alcohol intake has stopped or has been significantly decreased. The disulfiram is a potent alcohol dehydrogenase inhibitor. and blocks the oxidation of alcohol at the acetaldehyde stage by inhibiting the enzyme aldehyde dehydrogenase. With alcohol ingestion, disulfiram causes the patient to feel extremely unpleasant sensations ranging from flushing, dyspnea, and tachycardia to confusion, vomiting, and syncope. Unpleasant symptoms can last from 30 minutes to 2 hours, and the intensity of the reaction depends on the amount of alcohol ingested, the dose of disulfiram taken, and the time that has elapsed between the two. The theory behind disulfiram use in the treatment of alcoholism is based on aversion. Acute reactions may be fatal. Topiramate is a seizure medication that may curb the craving for alcohol. This drug acts by reducing excess dopamine release through alcohol consumption. Researchers have found that patients given this drug were 6 times more likely than those taking a placebo to abstain from alcohol for a month. Buprenorphine exerts its analgesic effect via high affinity binding to opiate receptors in the CNS. It displays partial mu agonist and weak kappa and agonist activity. So what is the cardinal points of treatment? The principles behind using medication for alcohol treatment involves helping patients who are dependent on alcohol reduce problematic drinking, deterring relapses back to heavy drinking, achieving and maintaining abstinence from alcohol, or a combination of these effects. Pharmacological treatment options include oral naltrexone, Revia, is the generic form, the long-acting injectable form of naltrexone, Vivitrol, acamprosate, and disulfiram. Disulfiram functions on the aversion model and is a significant physical deterrent to alcohol because it causes unpleasant physical symptoms when alcohol is ingested or inhaled. The drugs may be taken while people are still drinking, except for the disulfiram. During the initial phase of alcohol withdrawal, up to 5 days, benzodiazepines do help to physically stabilize the patient. Medication use is successful with programs that integrate social support to motivate and educate patients on the adverse effects of alcohol and to help them redirect their lives. For treatment of drug-related problems, naltrexone injectable can be used to reverse the signs of respiratory depression in patients with opioid overdoses. Alcohol abuse treatment, non-pharmacological treatment is the foundation of any therapy. Counsel all patients about safe levels of drinking. Self-help groups such as Alcoholics Anonymous can be found at the National Clearinghouse for Alcohol and Drug Information website. Professional counseling may help. Hospitalization is not necessary for treatment to be successful. The partnership at drugfree.org is a website for parents to help them prevent drug use among their children, intervene, educate, and understand treatment options. The site offers up-to-date information about current synthetic drugs such as spices and bath salts. A list of organizations where parents can find help for their children is also provided. Pharmacological treatment has had limited success but may be helpful when patients are dependent on alcohol. Medications are used with supportive treatment to maintain sobriety when patients are unable to do so through traditional approaches. Naltrexone, an opiate antagonist, is useful for an adjunct to psychosocial therapy. It works by decreasing alcohol cravings and can be used on long-term basis. Acamprosate can be used alone or in adjunct with naltrexone. Dangers are inherent in the use of disulfiram, and abstinence from alcohol is required. For alcohol withdrawal, benzodiazepines play a large role in preventing seizures and other complications. For milder symptoms, clonidine, atenolol, and carbamazepine have been used successfully. The CIWA-IAR Clinical Institute Withdrawal Assessment of Alcohol Scale Revised is an assessment tool that was designed to evaluate the need for medical treatment for withdrawal. It includes an interactive training package that is suitable for practitioners who treat patients with alcohol misuse. This is often used in the hospital, and you'll hear it called the CWA. Opiate abuse treatment. Naloxone is an opiate antagonist with a short duration of action, 20 to 60 minutes. It's given sub-Q IM or continuous IV infusion. This is generally done in the emergency department setting to counter respiratory depression due to opiate intoxication. Naltrexone is considered considerably more active than naloxone and has a 24-hour duration of action. Opiate antagonist activity is related to dose. A single 50 to 100 milligrams oral dose of naltrexone effectively antagonizes the pharmacological effects of 25 milligrams of IV heroin for up to 24 hours. A single IM injection may antagonize heroin or other opiates up to 2 to 4 weeks. Nalmefene, which is structurally related to naltrexone, is indicated for reversal of opioid effects and for opioid overdoses. It has a longer duration of action than naloxone at fully reversing doses. Methadone is dispensed by both pharmacies and licensed narcotic treatment programs approved by the DEA and designated state authorities. Strict requirements for use are stipulated in the federal methadone regulations. Methadone used as an analgesic may be dispensed in any licensed pharmacy. Buprenorphine or a combination of buprenorphine and naloxone is a sublingual treatment that is started when a patient experiences with signs of withdrawal. How do we monitor naltrexone? Monitor heart rate, blood pressure, and respiratory rate. Monitor kidney and liver failure. Monitor response to therapy and abstinence from alcohol, as well as risk of suicide, which often is increased in those with substance and abuse problems. For acamprosate, should not be used with renal impairment with creatinine clearance less than 30, maybe given if creatinine clearance is 30 to 50, and you need to provide that the patient is monitored regularly. The risk of suicide is also increased. For disulfiram, monitor the liver toxicity, check LFTs at baseline weekly for 4 weeks, biweekly for 4 weeks, then monthly. You need to monitor for jaundice or for evidence of liver toxicity. You need to monitor for symptoms of optic neuritis, such as eye pain or visual disturbances, and monitor for symptoms of peripheral neuritis, such as tingling and numbness in the hands and feet. Monitor for headaches, drowsiness, and psychotic reactions. Assess compliance with drug therapy, abstinence from alcohol use, and progress of therapy. Again, some treatment models combine alcohol treatment with medications, with behavioral counseling. Benzodiazepines assist in psychologic stabilization of patients in the first 5 days of alcohol withdrawal, and medication use with programs integrating social support is successful in helping to motivate and educate the patients. The drugs alone will not do it. For patient variables, Geriatrics, naltrexone, you need to use with caution with patients with renal or hepatic failure. Acamprosate has not been evaluated. Use caution when monitoring renal function. And disulfiram is of limited benefit in geriatric patients because of the cardiac risks. For pediatrics, the use has not been evaluated. And pregnancy and lactation, the category C, naltrexone, acamprosate, disulfiram, and for lactation, safety is unknown. For patient education, naltrexone, tell the patients to wear a medic alert bracelet or carry ID and notify healthcare providers that they are taking this medication. Tell the patients if they take heroin or other narcotics with this drug, they may die or sustain other serious injuries, including a coma. If the patients previously used opioids, they may be more sensitive to them after using Vivitrol. Healthcare providers should monitor for signs of liver toxicity, such as abdominal pain, white bowel movements, dark urine, yellowing of the eyes. With Vivitrol, if patients have signs or symptoms of pneumonia or respiratory distress, they may have allergic pneumonia, which requires special medical treatment. With Vivitrol, if the injection site exhibits a reaction that does not resolve, patients should get medical attention. Also, once patients receive the injection, it cannot be removed. If they become pregnant or are lactating, patients must notify their healthcare provider. For acamprosate, the patient may take this agent with other alcohol treatment medications, but not with moderate kidney failure. If feeling depressed, the patient should notify the healthcare provider immediately. For disulfiram, you need to instruct the patient to avoid taking this medication if they are unwilling to make the commitment to not drink. Tell the patient to wear a medical alert bracelet and notify the healthcare provider if they are taking this medication. Reaction can occur up to 14 days after the medication is taken, and they need to seek medical attention or notify a healthcare provider immediately if the patient experiences any chest pain, respiratory difficulty, or jaundice. The healthcare provider should monitor for signs of liver toxicity such as abdominal pain, white bowel movements, dark urine, or yellowing of the eyes. And finally, if they're feeling depressed, the patient should notify the healthcare provider immediately.